Well, very good morning. Continuing with the medical sessions after the amazing session on surgical retina, we now move on to medical retina. This session is basically aimed for comprehensive ophthalmologists to make them aware of some of the situations which are coming up a lot in retina practice, and many of them can be confused with something else, or they're a bit unusual. When you look at the patient, you are kind of perplexed as to how would you proceed. Since cases are the integral part of retina and you actually learn, and even when you are in a meeting, if you are shown a case, you are able to relate to it. The format of this particular instruction course is going to be in the form of case presentations. So we have an amazing panel which has most of the team from Advanced Eye Center at PGI Chandigarh, including my colleagues Dr. Mohit Dogra, Dr. Reema Bansal, Dr. Diksha Katoch, Dr. Simar Rajan Singh, Anirudh, who has been our alumni, and then there is Professor Atul Kumar from AIIMS, who will be joining us shortly. So without wasting much time, and I would request for those of you who wish to interrupt the speaker or want to go over something, please feel free to stop so that we are able to, learn from some of these situations. So with this, it's my privilege to invite Dr. Diksha. We had to change the sequence a little bit because Dr. Diksha has to go somewhere else for another meeting. So Dr. Diksha is going to talk about relevance of vitelliform-like lesions in age-related macular degeneration. So this is something which is important to know because identifying the vitelliform lesions is very important. If you do not identify and keep on injecting anti-VEGF, you will be wasting a lot of resources and the patient's money. So Diksha is going to show us illustrative cases as to how to suspect and diagnose vitelliform degeneration. Yes.
Thank you, ma'am. Thank you very much for this opportunity. I will be talking on relevance of vitelliform lesions in age-related macular degeneration. So as per the current understanding, vitelliform lesions that we know of are either hereditary, or now we also know that they could be acquired form, which are known as the AVLs. The hereditary forms are traditionally, we kind of related with the Best vitelliform dystrophy, usually presents by the second decade of life, the typical egg yolk lesion that is seen. But we also know that there is an adult form of this dystrophy, which is also associated with BEST1 mutations, can be associated with the peripheral RDS mutations, which has a later onset. Apart from that, there are conditions where you may have acquired vitelliform lesions, and some of these conditions include age-related macular degeneration, central serous choroidopathy, ocular inflammations, drugs such as pentosan, and even tractional maculopathies. The clue is to differentiate these two forms so that, as ma'am said, we do not intervene unnecessarily. Why we are clubbing them together? Because they seem to have a common pathway of pathogenesis, which involves either an inherited or an acquired RPE dysfunction and a loss of apposition between the RPE and photoreceptors, which results in impaired phagocytosis and turnover of the photoreceptor outer segments, leading to subretinal, is the key word here, subretinal accumulation of vitelliform material, which has precursors of lipofuscin, melanolipofuscin, and pigment-laden macrophages, which impart common imaging characteristics regardless of the etiology. Let's go over this case. This is a 50-year-old male who presents with diminution of vision in both eyes, slowly progressive over the past 3 years. He has received 2 anti-VEGF injections elsewhere for a diagnosis of a choroidal neovascular membrane. Visual acuity is 6/24 and 6/12, and if you look at the fundus, the macula has symmetrical appearance of yellowish white round to oval lesions in the central macula, surrounding by a layer of hypopigmentation. If you do an OCT, you see that this deposit, as we may call it, lies between the RPE and the photoreceptor layer. There is associated subretinal fluid. Notably, the foveal contour is not disturbed. There is no intraretinal fluid, and also the RPE does not have any sub-RPE components. Similar appearance to a lesser extent is seen in the left eye. The autofluorescence, though not very characteristic as we see it, but yes, it depends on the amount of lipofuscin in this material, will be brighter as we see in the right eye, not so much because of the quantity of the vitelliform material is less in the left eye. If you do a fluorescene angiography, it is going to show that the central lesion is hypofluorescent and the surroundings may form like a ring of hyperfluorescence. In the late phases, that central ring may show some hyperfluorescence, which often confuses it with the late choroidal, which is known as the occult CNVM. So the angiographic picture may be confusing. So, and similarly in the left eye, we see some late hyperfluorescence coming up from center of the lesion, which may confuse it as an occult CNVM. But if you do an OCTA, this is the NFAS imaging, the deposit is hyperreflective in the outer retina. Also, it is extending into the deeper layers. And if you see the flow, there is actually no flow in the lesion, within the lesion, and also we do not see any choroidal neovascular membrane on the OCT angiography slabs. Similar appearance is there in the left eye, and correspondingly we do not see any choroidal neovascular membrane, and neither is there any flow in this lesion. If you do an EOG, this is normal in this case. So just to differentiate what AMD and AOFD, the vitelliform, adult onset vitelliform dystrophy occurs a little younger than AMD presentation, usually in the 4th to the 6th decade. Patients are generally asymptomatic or may have minimal visual symptoms, generally non-progressive or very slowly progressive. Drusens, which is a hallmark of AMD, are not rarely that often seen in the vitelliform dystrophies, though they may be subtle. Sometimes they may be accompanied by cuticular drusens. So we should not confuse. In 33 to 60% cases, there may be some drusenoid deposit accompanying them. Pigmentary abnormalities are seen both in AMD as well as the vitelliform, though in the vitelliform degeneration, the pigmentation is mostly central and surrounded by a hypopigmented halo. The key on OCT is the subretinal location of this deposit vis-a-vis the sub-RPE location of the hyperreflective material in AMD. Fluid in AMD can be in the subretinal, intraretinal, or the sub-RPE compartment, whereas fluid mostly will be in the subretinal compartment in the vitelliform, and very rarely will you see accompanying intraretinal fluid. EEG can be normal in these cases, and fundus autofluorescence shows a central hyperautofluorescence corresponding to the deposit. In the late stages, there will be irregular RPE loss. This is another one of our patients. Here we see the typical fundus autofluorescence, which is showing a bright hyperautofluorescence corresponding to the vitelliform deposit. And fluorescene angiography, I would like to again reiterate, may be confusing in these cases. The natural course is biphasic. There is a period of growth followed by resorption. The resorption is accompanied by focal loss of the outer retinal layers, mainly getting affected the outer nuclear layer, the ISOS junction, and the external limiting membrane. Thinning or loss of the RPE can be there, and the ISOS junction and external limiting membrane loss generally results in the decline in visual acuity. Choroidal neovascular membranes are in general rare in this disease, and if they do occur, they are mostly the type 1s. But majority of the patients tend to retain reading vision in at least one eye throughout their lives. This is another one of our patients. Now, if you see the typical lesions, subretinal here again, over a course of 5 years, what is happening to the lesions? In between, we see that the pigment migrates into the intraretinal compartment, then gets reabsorbed. Ultimately, there is resorption of the material with loss of the ISOS junction and the external limiting membrane. Whereas in the other eye, we did see migration of the pigment into the intraretinal compartment, but there is absorption, but the outer retinal layers remain preserved, and that is why this patient has good visual acuity in this eye. EOG again is normal. The subretinal fluid in these cases generally is a result of the mechanical displacement between the outer retinal layers and the RPE, from pumping of the liquefied lipofuscin, and it happens during the course of the disease when this vitelliform deposit tends to get reabsorbed. We can see this happening in both the eyes. Now the only question is, how do we know when do these patients actually develop a choroidal neovascular membrane? So a split in the retinal pigment epithelium basal lamellar Brooks membrane band means if you start seeing something happening below the RPE and you start seeing intraretinal fluid coming up, that is the time we need to suspect that these patients have developed a choroidal neovascular membrane. So take-home messages are acquired vitelliform lesions occur in a variety of different clinical entities. They share common fluorescene angiography, OCT, and FAF features regardless of the underlying clinical diagnosis. The diagnosis of choroidal neovascularization in the setting of vitelliform lesions using fluorescene angiography can be challenging. So we have to integrate multimodal imaging, and most of the time a combination of an OCT and fundus autofluorescence clinches the diagnosis. If you have OCTA, well, that can add definitely. And this can help refine management and avoid unnecessary interventions and follow-ups in such patients. Thank you.
Thank you very much, Diksha. My question to you would be, when you look at a patient of AMD, clinically, what makes you suspect vitelliform?
Ma'am, if we look at a patient, first we look at the drusens. A patient of AMD, the hallmark feature which we see are the drusens. Now, if we see only small drusens, we are not seeing the intermediate or the large size drusens. If we see any intermediate or large drusens and bilateral, then they will fall towards the AMD group. But if the lesions of the drusens are generally smaller, and you are seeing this yellowish lesion right in the front and on the OCT, which is subretinal in location, then we start thinking, and bilateral, then we start thinking of a vitelliform dystrophy.
So if you are thinking of vitelliform, you will not really go for fluorescene angiography,
yes.
no?
Yes,
it's
absolutely.
Better just to do OCT and look at the flow.
Yes.
If there is no flow, it's more likely to be vitelliform, and there is no hurry to inject.
Absolutely.
And as you said, on OCT, the location would be subretinal and not sub-RPE, which would be in AMD. Any questions for Dr. Diksha? Well, thank you. If there are none, thank you, Diksha. Any advantage of ICG to differentiate AMD from Aovfd?
Yeah, if you talk of an angiography, ICG does add value because the lesion that you see, the hypoautofluorescence, the hypofluorescent lesion which you see on the fluorescene angiography and the late hyperfluorescence, that is not seen on the ICG angiography. So there will be no leak and no corresponding leak on the ICG. Though ICG is not really required, most of the time an OCT and a fundus autofluorescence is enough. But if you have ICG, then that can add on to your diagnostic capabilities by not showing any choroidal neovascular membrane or leak on the ICG, which is confused on the fluorescein, where you see sometimes a late staining of the lesion, which is confused with the late occult CNVM.
The image that was presented by you.
Can you please speak in the mic?
Your image of the ICG.
No, I have not presented any ICG. That's a fluorescene angiography. No, it's a fluorescene angiography on the spectralis.
On spectralis?
Yes, yes.
So I think what Dr. Diksha is saying, the ICG is basically to identify the membranes in AMD. In adult onset vitelliform, ICG is not going to show any features. And if you can look at the membranes either on OCT by looking at the flow within that hyperreflective material, or on OCT angio, so probably ICG is not required, but if you do not have OCT angio and you want to confirm whether there is a membrane or not, ICG will help. But ICG will be kind of not show any features in vitelliform. So that way it helps. Any further questions? Thank you, Dr. Diksha.
Thank you, ma'am.
With this, we move on to the second talk, which again is related to similar topic, that you have a patient with new vascular AMD, which is non-exudative. Or you have exudative non-new vascular AMD. Would you treat it or not to treat? So Dr. Mohit is again going to show you example of cases where AMD should not be treated or where there is a doubt about treatment. Over to you, Mohit.
Thank you, ma'am, and thank you for the kind invite to be part of this instruction course. Good morning, everyone. Very confusing and quite a mouthful. Neovascular non-exudative AMD and exudative non-neovascular AMD. I'm going to show you one example of each, and then maybe try and get around what these terms mean, and is it clinically relevant, and if so, then what do we do in these cases? So. Yeah, so this is case one, and case one is going to be a shorter, more quicker, kind of crisp one. Case two is longer, so we'll spend a little more time on that. So this was a fairly elderly gentleman. He presented with sudden painless decrease in vision in his right eye since 8 days. Had no complaints in the left eye. This is the wide field, the ultra wide field optos photo of the right eye. You can see that he has a submacular hemorrhage, covering most of the posterior pole and just extending a little bit past the arcades. And he also has evidence of having bled previously extramacularly, inferiorly. Now it's kind of gray. Some of it might be fibrosis. And, there are some pigment alterations in the other eye, also vision's down. That was the other eye, which was 612. That is, that is just an artifact, but that is what the patient had, and that is a blown up image of the same asymptomatic patient. 612 had a little bit of a cataract, wasn't pseudophakic. The right eye was managed first, obviously, because that was the eye which had, the more severe pathology, and that eye underwent vitrectomy with whatever. But that is not the cause or the topic for today. The left eye had, that was the clinical appearance. That was the OCT. You can see lots of those OCT scans. I'm just going to show up a couple of them. This is a little bit of a blown up image of the same. Nothing to write home about. I mean, you see a lot of what you would normally label in a busy clinic as dry AMD changes. This would typically be clubbed into this is dry AMD. Has drusens. There's no subretinal fluid, there is no intraretinal fluid, there is no sub-RPE fluid, and there is definitely no subretinal hyperreflective material or SHREM. So there is no evidence on cross-sectional OCT of any exudative activity happening within the retina. Hence, as of now, this is non-exudative. When you go ahead and perform an optical coherence tomography angiography, in this patient, however, you can see that, in the outer retinal slab, you can see this butterfly-shaped lesion there and the other one there. And if you were to, it co-localizes with that kind of a double layer sign which you actually saw on the previous OCT, and the flow is actually showing you that there is flow in it. There is increased flow in it. So all of these things are marrying together, and what they are essentially telling you is that sitting beneath those shallow kind of pigment epithelial detachments, that double layer sign is a neovascular complex, as you can see there. Last slide for this patient, and then we come to a little bit of a discussion as to what is what. So before we come to this, I think it's important to just recap what this patient had. The OCT, the patient was asymptomatic in this eye. The OCT showed no evidence of fluid or subretinal hyperreflective material. However, on optical coherence tomography angiography, the patient had evidence of a neovascular membrane. So what this patient essentially has is, he has a neovascular membrane, so this is neovascular AMD. Sorry. So the patient has a neovascular membrane, so this is neovascular AMD. It is not exuding into the retina, so this is non-exudative neovascular AMD, right? And so this is what we did to the patient to this eye, which is basically watchful observation. So we did nothing for this eye. We did counsel the patient. We'll be coming to the last slide for this patient, and then I'm going to talk to it. So in 4 months down the line, 4 months later, you can see that the vision's the same. The patient is still not symptomatic in this eye. The OCT is the same. However, on OCTA, the membrane seems to have, if I can use the term, sprouted some more vessel. It's now a more robust membrane, if I can use that term. You can clearly see it. there. However, the patient still continues to be and fall into the group of non-exudative neovascular AMD, which brings me to my caveat here, which is that patients with wet AMD, and this is wet AMD, right, because it has a neovascular complex, with angiographically detected neovascular complex. So, and that might be detected on FFA, on ICG, on dialysis angiography, as was done in our case. If there is absence of subretinal, intraretinal, sub-RPE or SHREM, basically no exudation on OCT, then at this point in time, you will label this patient to have a non-exudative neovascular AMD. Close follow-up is recommended, and there is no need of anti-VEGFs at present for these lesions. However, these patients have now, in multiple studies, been shown to have very, very high rates, very, very high chances of converting to exudative AMD, and people are trying to look at certain biomarkers on OCTA, whether they can predict that which patient is going to convert to an exudative state or not, and preempting treatment, whether if you start treating at this point in time, can you prevent exudation? Can you maintain good vision? However, as things stand of today, for non-exudative neovascular AMD, watchful observation is recommended, but with the rider and the patient understanding that regular follow-up is definitely needed, because they have from 6 to a 14-fold increased risk of developing exudation over 2 years. So that's a pretty high risk. But as of now, close observation with no injections. Sorry?
Yes. I think this is not on. But did you specifically test for metamorphopsia?
Yeah, so we didn't test for metamorphopsia, but we just asked, and we specifically asked, but a objective test for metamorphopsia was not done.
Because many of these patients will have subtle metamorphopsia when you test them.
Absolutely, sir. I agree. But I would trust a fairly elderly man who's lost his central vision in one eye to complain to complain of metamorphopsia in the only functional eye, in the only reading eye. I mean, he's lost a lot of vision in the other eye. So I would give him the benefit of doubt. I think he would be able to perceive his metamorphopsia.
So Mohit, the question is, if this patient had metamorphopsia, would you inject?
So if he had metamorphopsia at the outset, when I saw him for the first time, I would observe him a lot more closely, and maybe a week, maybe 2 weeks later. But if there was new onset of metamorphopsia while he was on follow-up with me, with all other factors being same, no exudation, I would tend to inject. But
so what Mohit is saying is that you have non-exudative, no fluid. OCTA shows a membrane, but that's not an incidental membrane. Like if it is incidentally detected on OCTA, probably you would observe. If it is detected with the complaints of metamorphopsia, again, there are two schools of thought. Some people might inject straight away, but what Mohit is suggesting is he would still observe for some time to see a change in the character of the membrane on OCTA or change in the symptomatology, because he feels that at this particular age, metamorphopsia symptoms could be kind of not very reliable. Am I right, Mohit?
Absolutely, ma'am.
So I don't think there is any consensus. It depends on you. But he's shown beautifully the change in the character of the membrane. It's becoming more visible, more robust, more new vessels. So I think, yes, on follow-up, if there are symptoms, one should inject. There is another question, Mohit. I think there are questions related to this case, so we will do this case only.
Sure, ma'am.
Yes,
sure,
please.
Secondly, may I ask one question?
Of course, it's instruction course.
What was the treatment given for the other eye, the right one?
So, I mean, the patient was subjected to pars plana vitrectomy, subretinal, with ILM peeling, with subretinal TPA, sterile air injection, SF6, partial gas fill, and a propped up position. That's what the patient had.
Anti-VEGF was not injected? Anti-VEGF?
Anti-VEGF was given post-operatively. I tend to not give a cocktail during surgery. It was given later.
Post-operatively.
I don't tend to combine that in my subretinal cocktail.
How many anti-VEGFs were given in this 4 months period?
For the right eye?
Yeah.
2.
Is it not that some systemic absorption has occurred and has held up the progression of the disease a little
In the left eye.
in the left eye.
It's a remote but a distinct
Definite
possibility, sir, which we can't prove or disprove.
So it's remote, but it's a definite possibility.
Absolutely, absolutely.
Yes, please.
Dr. Mohit, we all know that anti-VEGFs tend to work when the vessels are a little more fragile, when they're, the neovascularization is early. And you know that silent exudative CNVMs are definitely going to become exudative at one point of time. So you are suggesting that, I know that it is the correct, that we tend to observe till it becomes exudative and then we start treating.
That is the recommendation. I mean, there's no strong recommendation. Because my point against that is, if supposing we were to inject this patient when
so what I'm asking is, would it be a good thing that you treat the disease early? The moment you see a CNVM, probably treat them early. Probably tell the patient that you might lose a couple of letters. That's okay. But you would definitely reduce the injection burden of the patient if you start treating early.
There is no data to suggest as of now that the injection burden goes down. It is a distinct possibility and people are looking at it. And for me, the issue is if we start treatment for non-exudative, what is the end point? The vision is now, the patient doesn't have symptoms. So symptomatology is not an endpoint. There is no fluid. So, and we don't have an endpoint of the OCTA membrane, so-called. Or we wait for the membrane to be crenated and get that dead tree appearance. If that is the endpoint, then maybe that could be an option. But for me personally, as of now, I don't think if it's asymptomatic, even if it's a practically one-eyed patient who understands that he needs to follow up, but there is absolutely no, because if the patient is not going to follow up, I don't think he's going to follow up for the injections also. At this point in time, there is no tangible endpoint if you start injections for him also. So that is, for me, I think also, as of now, a little bit of lacuna where we don't know if we were to treat these, where to stop.
It is like when you do an MRI on a normal patient, you see so many hyperreflective lesions. You cannot start treating MRIs. So similarly, when we are doing OCTA, like Mohit has shown beautifully, we are seeing some membranes, but that doesn't mean we start injecting unless the patient has symptoms, and there is a definitive endpoint which you are trying to achieve. Till the time we have some level 1 evidence are the trials. I think this is what everybody is following, because the endpoint has to, there was a phase of enthusiasm when everybody started injecting, looking at OCTA. But then you realize for how long? Because the membranes just stay the way they are. So one last question and then we move on. Your mic is not.
No, actually, you said that if that disease is non-active or it is stabilized over the OCTA, then we should wait. But if the progression is recorded, as in Mohit's case, the progression is there. See, we treat HSTs, we treat retinal holes and breaks. For why? Just to ensure that there is no detachment in the future. In the same scenario, if we treat the CNVM in this stage in which the progression is documented.
He's documented. Now he needs injection.
So progression is, once the CNVM is there, you cannot give back that quality of vision by any means available till today.
Absolutely,
so it's
sir.
better to preserve, and he's almost uniocular, and he's almost uniocular. You yourself said that there are 6 to 14% chances that he may develop.
I think that's what he said, that he will observe, and if there is progression, he would inject.
So if the progression is there on the OCTA in asymptomatic patient, I think
you would inject. That's what he said also.
So at the outset, no injection for this patient, but at the 4-month follow-up, given the thing that he had injection for the patient. This is, I mean, this caveat is for the presentation for the imaging at presentation. So to see, if you were to just see the membrane de novo, not to inject at that point in time. But if you can, as we were able to show that membrane going, getting more robust and very, very clearly increasing, definitely injection for the patient at that point in time.
Your presentation definitely has given a new insight, as well as Dr. Udisha's presentation also.
Thank you.
Thank you very much. And I'm sure the next presentation is going to be equally enlightening by none other than Professor Atul Kumar, ex-chief of RP Center of Ophthalmic Sciences, AIIMS. So sir is going to talk about very interesting topic about disorganization of inner retinal layer, drill. So what, when you see drill in macular edema, so is it going to change your approach to management? Because earlier we were talking about identifying these entities, but now that we recognize them, do we change our management? Over to you, sir.
Thank you, Professor Vishali. I'm much honored and feel thankful for having been part of your very honored course, and it's a pleasure to be speaking to all of you here, people who've come all the way from various parts of India to attend this meeting. And these courses are very academic, and I hope you understand what I mean. If you have a course conducted by Professor Vishali, it has to be very academic. So I'm going to talk about this biomarker, which is very important, and it's been identified in the last few years. And diabetic retinopathy or diabetic macular edema, they have biomarkers now, various biomarkers. So drill is one of the very important biomarkers, and you must understand these biomarkers when you treat diabetic macular edema or any kind of diabetic retinopathy, or you look at the picture. So you study the morphology, don't just see the vision, because study the morphology, see the inner layers, the outer layers, the ellipsoid band, all that has to be seen in its totality, and do it yourself. Check the scan yourself. If you don't check the scan yourself, or go to the imaging room and sit there and see the scan, sometimes when you see it live on the screen before the printout, or before it's sent to you, the image is sent to you probably, it's very best to see it. If you have the access to the screen in your own office, it's fine. But this particular biomarker was first described by Sun, and this was as late as just 6-7 years back. But that was the initial time when things started getting picked up more in diabetic macular edema and diabetic retinopathy, the OCT features. So it was basically the inability to distinguish the inner retinal layers, the ganglion cell inner plexiform layer, the inner nuclear and the inner outer plexiform. The inner plexiform, outer plexiform, inner nuclear layer and the ganglion cell layer were indistinguishable, as opposed to the outer bands, which are also very important. So the entire retina is very important. The vitreoretinal interface is very important in diabetic retinopathy. Each part of the OCT is very important. So it may take you a few minutes, or maybe a minute or two if you're very experienced, but otherwise spend time on seeing the image. And that's the proper imaging. You'll kind of get a thrill, an understanding which is much beyond of what just rapid go through a gross look at the images. So that's what my first thing would be to all of you. So drill basically is in the central 1000 microns, the central subfield thickness. If you see the grid shows the central 1 millimeter zone, which is in the central, which is also called the central subfield thickness. That's 1000 microns. So if 500 microns of that 1000 microns in width is involved, it's called drill. That means your inability to distinguish the inner segments. Now this is a marker which is basically suggesting impending or already setting in neuroretinal degeneration. It's not just cystic fluid or something which is going to be treated by anti-VEGFs. So it has a bigger challenge in the treatment. So anti-VEGF right, left and center, as you keep hearing from various sources about Paginex and problems about no problems in Paginex, and I keep reading about uniocular patients not to be given, ocular inflammation not to be given, occlusive retinal vasculitis, please, it can occur. So I'm very wary of giving Paginex. I'm not industry driven at any cost. So I'm not going to attend or take part in any of the courses where there's a push by a particular industry, because everybody's got his own views. My views may be totally in isolation, but that's the way I would like to say it in front of all of you, that please don't be driven by somebody, but take your own assessment. That's going to make you a better professional. So it's a neuroretinal degeneration which is not specific to DR, but it's mostly seen in diabetic retinopathy. It's a problem which is rampant in our country. So it's seen in refractory DME. So refractory DME who's already got anti-VEGFs has been treated for center involving DME. We know non-center involving DME, it's possibly you'll do a focal laser. But nobody's going to have a lunch hour session on laser, because laser is not having a father or a grandfather behind it. There's no Genentech and there's no Bayer behind them. So that's the situation, things are different. So there's a disruption of the inner retinal layers. There's reduced perfusion, so the vascular and the neuroretinal degeneration sets in. And this is the way it looks like. You get not only this, but you get hyperreflective foci, which are inflammatory biomarkers. You may get a ORT, outer retinal tubulation. All these are biomarkers. Some are inflammatory biomarkers, but this is also thought drill is thought to be partly post-inflammatory. So that's why the role of steroids comes in, because if it's a refractory DME not responding to anti-VEGFs, there's a definite role of the interleukins, leukeins getting in, and actually the inflammation is not taken care by anti-VEGF. So just because of the vascular instability, which is the anti-VEGF role, you can go beyond anti-VEGF. So now you've got faricimab, which is actually a drug which is going to Ang2 inhibitor plus the anti-VEGF inhibitor. So various combinations and permutations are coming in. So it's basically indicates severe DR, probably more chronic DME, more refractory DME, and you have all these pictures, multiple pictures everybody's seen, so it's nothing new what I'm showing you. It's a serious detachment. The segmentation of the retina is kind of difficult in the inner segments. The ellipsoid band is visible. It seems to be somewhat continuous. There's an epiretinal, so the vitreoretinal interface shows some ERM growing over, or a thickened hyaloid which is growing over, pulling up the retina. So you've got cystic fluid, probably early setting in of ORTs also. Now these cysts are not cystic macular edema. So look carefully. If you've got a hyper reflective boundary or a hyper reflective wall to these cysts, it's probably an outer retinal tubulation, which is a sign of neural degeneration of the retina. So that's not going to be taken care by anti-VEGF. You probably may even worsen the patient, or he's not going to improve. He's going to be very unhappy. You'll have an unhappy patient on your hands. So the question answer as given to me is that what would I do if there's a refractive DME with drill? The way you saw it on the OCT there. So probably I'll still inject. There's thickening of the central subfield, 1000 microns. I might shift to steroids. I might give a dexamethasone implant. And many patients, you tell them carefully, you go talk to the patient. You just can't tell him, I'll give you the injection. So you tell him what it is, show the image, and discuss with the patient. He's ready. And actually, these are they are anti-inflammatory and anti-angiogenic. So they improve the vascular stability, as also the inflammation which is there is kind of gets lower, gets down, and then probably check the vision, morphology, and the central thickness over a period of time. If no response, my approach would be, I'll give a steroid, and then my approach would be, if there's no response, probably discontinue therapy altogether. But I'll try to see the periphery of the retina, also see the metabolic control. Everything goes hand in hand. It's a multifactorial problem which you got to deal with. So they've shown that they had, there have been reports that from one of the pioneering work that showed that drill had some improvement of one line. So take home message, just don't look at the thickness of the center, also look at the morphology of the retina. We don't understand what's the threshold for drill and when to inject, when not to inject, but probably if you feel that patient's got a little thickness is there and there's no atrophy which is set in, you might like to shift to steroids and give steroids. So this is a patient where I gave Ozudex. You see central outer retinal tubulation, and that's setting in, and there's no segmentation so well seen. There's some interhyaloid remnant, so you can do a dynamic focus on the Triton machine or the Heidelberg and check all these things, and you can see the multiple hyperreflective foci. The hyperreflective foci, as opposed to hard exudates, don't cast a shadow, and they may be smaller, but they coalesce, maybe form a hard exudate, so we don't know. But it's a sign of the degeneration which is there, inflammatory biomarker. Thank you very much.
Thank you, sir. That was really a very clear message that drill is going to happen to the patients who probably would have already received anti-VEGF, because it's not very commonly in treatment naive. So if you have drill and hyperreflective foci and other changes, probably moving to steroids may be a better option. So any questions for Professor Atul? Thank you, sir.
I'll be happy to answer any question. Thiru, you have anything?
Yes.
Can you take a mic? I know you're going to your voices will reach us, but you know, it's clearer to everybody.
Yeah, it's getting.
Would you combine giving an anti-VEGF with a steroid in these sort of cases where you have...
following protocol U,
yes,
I think I'll just give a DEX implant only. Because ranibizumab with DEX implant didn't show better results. Those are a short-term study, 6 months only. But if you follow the drcr.net, it doesn't show any advantage. And actually, I have not seen advantages. So if you get DEX implant, I just give it on its own. That's it. That's my approach.
No, why I ask this question is because when you combine treatment in these sort of cases, you are addressing both the VEGF drive and also the inflammatory component. So,
okay.
Thank you, sir.
But they take care of both, the steroid.
Thank you, sir.
There's been a recent report on fluocinolone also, that it helps over 3 years, but then there are problems of glaucoma and all that. Many of these studies are there now.
The question was whether would you like to combine ranibizumab with Ozurdex, and the answer was very clear that if the patient has not previously responded to anti-VEGF, please move to steroid alone and see what happens. Yes, Nishat, there is a question.
Sir, how will you manage a patient with a proliferative component with drill?
You mean protocol S? In the proliferative DR, there have been reports by Bressler et al. That in protocol S that it's controversial, this particular drcr.net report, that in PDR the anti-VEGFs versus laser, they do better. But if you combine the two, actually go a little off the report, and then you find better results. Because if you only inject anti-VEGFs, the ischemia increases. You may have less vitrectomy, less DME, but they've shown the ischemia goes on increasing. So there are little controversies. And probably in PDR, if you don't have traction at near the close to the macula, you can continue with the anti-VEGFs. But finally, you might have to resort to laser also, which is very definitive, and also maybe surgery. But I suppose there is a role of anti-VEGFs in PDR.
So you will not consider steroids in that or DEX implant in such a patient?
Probably I'll prefer anti-VEGFs there first.
I think if there is a component of proliferative diabetic retinopathy, we all go in for anti-VEGF. One last question, please, ma'am.
Okay, so I would like to ask, in a treatment-naive patient with a lot of intraretinal fluid along with drill and other findings that you discussed, what would be your first choice of treatment, anti-VEGF or DEXA?
Anti-VEGFs.
Okay, thank you.
But if there are hard exudates in the center, more of exudative component with a lot of hard exudates in the center might go in for a DEX.
And also one thing which Professor already highlighted was the systemic control. Because many of these patients, like what you are describing, would have some renal involvement, some metabolic, problems, deranged lipids, and addition of something as simple as lipid lowering helps in tightening the barrier as well.
Definitely.
So that Professor Atul already highlighted.
Thank you.
Well, thank you, sir. Thank you so much. And with this, we move on to our next presenter, Professor Reema Bansal. Very interestingly, she is going to talk about leopard skin appearance in patients with exudative retinal detachment. This is what perplexes the retina surgeons because you keep on hearing talks about lymphoma, so she is going to tell us when it is likely to be lymphoma and when something else. Over to you.
Thank you, ma'am, for this opportunity, and a very good morning to all of you. So, leopard skin appearance in a patient with exudative retinal detachment. So the picture that you're seeing is not always the clinical scenario that we may encounter when we see the patient first. So I'm going to show you 3 cases where the leopard skin appearance may be present along with retinal detachment, or it may precede retinal detachment, or it may be seen just after the retinal detachment is resolving. So case 1 was a 47-year-old male who presented with this kind of picture, and he was referred to us after having been seen by multiple centers and with varying differentials, like he was treated as a VKH disease. He was also treated as chronic CSC and Lyme's disease and had been subjected to oral steroids, IVMP, posterior subtenon, Kenacort, and all combinations. So when we saw this patient, we saw that his inferior periphery in the right eye had bullous retinal detachment, and left eye we could see these prominent pigmentary changes, which were of course present in the extreme periphery and likely to be missed on just gross posterior pole examination. So thinking of this as having been, subjected to various kinds of treatment and all, so we did the refraction of this patient, and we found that he was found to be high hypermetropic. We subjected him to MRI for the scleral thickness, and his scleral thickness was found to be high. His exi lens were short in both the eyes. And this is how, when we were observing him and when we were working him up, his right eye retinal detachment spontaneously regressed. And you can see the pigmentary changes now becoming more prominent in the right eye. However, his left eye was not resolving, so he underwent subscleral sclerectomy. And this is the follow-up at 3 years, where you can see the leopard skin fundus being now very prominent on ultra-wide field photography in both the eyes. These changes are much more prominent in the periphery. And this is also in the autofluorescence, where the changes are very prominent, and you can see he's doing fine at 10 years. So to summarize, this case was actually a case of uveal effusion syndrome, where these pigmentary changes and the leopard spot fundus gave us a clue of, not treating this patient as what he had been treated before for. Second case was the daughter of this patient, who came with decreased vision in the left eye since 3 weeks, and on examination we didn't find very obvious cause. You can see the peripheral detachment, annular detachment in the left eye, which is shallow, and when we did the fluorescene angiography, all that we could find was some kind of hyperfluorescent leaks, and not enough to tell us of the diagnosis of what's going on. So unless we did the autofluorescence of this patient, and we found that these kind of leopard spot appearance was there in the left eye, and this gave us a clue of what was going on. And by this time, honestly speaking, we were not very familiar with the term familial uveal effusion syndrome to be running in the families. So we did her biometry, and we found that her exi lens was short, and we got the MRI done for the orbits, and we found that the left eye had ciliochoroidal detachment, which was seen on the fluorescene, along with subchoroidal effusion and mildly thickened sclera. So this was also a case of uveal effusion syndrome, where we could just pick up the leopard spot on the autofluorescence. And since when we did the OCT, we found the right eye was normal, and the bottom scan is the left eye, except some RPE, bumping. We didn't find any fluid. So we counseled the patient and observed her. We didn't do any intervention. So this is how she presented, and 18 months later, when we followed her up, she went on to develop this massive exudative retinal detachment in the left eye. So now that she had massive fluid, we offered her the treatment of subscleral sclerectomy, and she underwent that. So this is how she resolved following the treatment, surgical intervention, and just to compare, this is how she manifested. So this was exudative detachment that developed months after the leopard spot appearance that we saw on the fundus. So case 3, this was a 67-year-old woman who presented with bilateral loss of vision, light perception, and I'm showing the interior segment photographs, which they were not very normal to see on slit lamp examination. And if you carefully see, this was massive retinal detachment, bullous, lying just behind the lens. She was pseudophakic, and right eye, you can see the retinal vessels just touching the lens, intraocular lens. This was the extent of detachment in the right eye. Left eye. So we had various differentials and investigations. A 67-year-old woman presenting with visual complaints for almost a month. Both eyes, only light perception. General examination, she was lean, only 40 kgs. So we subjected her to all the tests because we didn't know what's going on. So much of bullous detachment in both the eyes. So we checked her for any malignancy, anything in the body. So all her radiological investigations, including CT chest, ultrasound abdomen, MRI, everything was normal. Hematology workup was normal. So this took us almost a week to complete the investigations, and she was the same with light perception vision. So we didn't want to delay any further. So we subjected her to a diagnostic vitrectomy because thinking of, we wanted to send the fluids for cytology and see what's going on. Is it lymphoma or what else? So her samples, vitreous fluid and subretinal fluid, were all negative for PCR, cytology and everything. So we just gave an empirical treatment for IV methylpred because that is the only thing we could offer. And by the time, 3 weeks, you can see the left eye is now showing the gas bubble. The retina is attached, obviously, for reasons that she had an internal tamponade. And now we are seeing this classical leopard spot appearance with subretinal fibrosis. And this is the time when we realized this is actually a case of VKH disease. So we started her, we gave her 5 IVMP, and she showed a very slow response. As you can see, this is how she was at the beginning in the left eye. And this is how the right eye was there at 3 weeks. So you don't see much difference. So she was responding very slow even to IVMP and oral steroids. So now you can see the tigroid fundus behind the detachment. So this is how she began in the right eye. So 3 weeks, if you look at both the eyes, the left eye is of course better because of the internal tamponade. And at 5 months, you can see bilateral picture of chronic VKH with Leopard spot, and this is how we realized that these can present with massive bullous retinal detachment even in an elderly woman, where all our focus was on lymphoma or some kind of masquerades. So this is the OCT on the right eye at beginning, and at 1 year she's doing fine. This is the OCT just after PPV and at 1 year. So this is how she was at the follow-up, and if you compare, this is how she was at presentation. So this is the 2 years follow-up where we had put her on immunosuppression. So you may not have, these are lot of entities where you have leopard spot appearance in non-exudative varieties like, benign familial flare retina, and if you go on, the list is endless. So when you have leopard spot fundus, how to proceed? If it is with exudative retinal detachment, think of VKH disease, uveal effusion syndrome, acute lymphoblastic lymphoma, hypertensive choroidopathy, even primary retinal lymphomas may be with or without exudative retinal detachment, and generally without detachments, chronic CSC, B-dump, Warburg syndrome, and of course many of the flecked retina disorders. So imaging is important in these because clinical examination, we may not always pick up the clues. So all that we need is, of course, good color fundus photographies. Autofluorescence gives you the best clue. Fluorescene angiography and ICG angiography to confirm your diagnosis. And OCT angiography to rule out any choroidal neovascular membrane, especially if you're seeing cases of CSC. Thank you very much.
Thank you, Rima, for showing those beautiful cases. So you showed us two patients like exudative detachment with leopard skin. One was VKH and the other was uveal effusion syndrome. Now for beginners and comprehensive ophthalmologist. Okay, there is a question. I will take that.
Is there any role of B-scan in your first case?
Because is there any role of B-scan?
Yeah, B-scan is for, you can do the axis length, of course, and the extent of retinal detachments, and you want to rule out any mass lesion underlying?
Now, in your first case, that case was misdiagnosed by many centers. So initially, they would have done the B-scan and picked up easily effusions and all that.
What you mean is the globe, the axis length of the globe?
No, I'm talking about the B-scan, not A-scan.
So probably the centers that treated this first patient did not do the B-scan, and the exudative detachment was not in the posterior pole. So I think it was in the extreme peripheries and that was missed. And since we didn't see the detachment in the posterior pole, we don't know whether the patient did present with detachments in the posterior pole to the primary centers.
We can do the transverse B-scan also.
We should, of course, we should.
I put this question other way around. Is there any role of B-scan in your today's, like Dr. Atul Kumar has said, is this industry-driven treatment protocol? Is there any role of B-scan?
Of course, in clinical scenarios, we always do B-scans in any patient who presents with exudative detachment, and usually our B-scans are combined with A-scans because we always pay attention to the axis lengths also.
That's fine. That's the two modalities. So, like old teachers, like if you are having the B-scan, then there's no harm in putting. Sometimes we are in very hurry.
No, we always do.
Yeah.
We always do.
Thank you very
much. Yeah. Another question?
Yeah, you mentioned the imaging modalities in that in the list was ICG angiography. Considering that this is a uveal disease, exudative disease, was ICG angiography done in any of these patients? And
no.
If not, why not? And if it was done, do you think it would have helped you closer to the diagnosis earlier?
No, not in these patients, but ICG is mainly required when you have a differential of chronic CSC in your mind. And any kind of posterior segment disease where you're not having any clue or you're not knowing, you don't know what you're dealing with, we do ICG angiography, of course, because there is choroidal involvement we have to do, along with fluorescene angiography. But since in these cases we picked up the clues on excellence, on MRIs, and on autofluorescence, we didn't really need to do ICG in these cases.
But I think if there is a confusion between the diagnosis of UES and VKH, ICG will very easily help you differentiate the two. VKH will show multiple small rounded stromal granulomas, whereas UES or CSR should not show those hypo to hypo lesions. So, though these patients probably did not require because they had good autofluorescence and other clues, but yes, it can be done.
There's also a paper by Bailey-Freund where they've described altered choroidal circulation and venous anastomosis which occurs in CSCR.
No, I'm not talking about the choroidal changes in CSC. I'm just talking about the granulomas. The hypo to hypo spots will be seen in VKH. What you are saying is venous overload, choroidopathy and all. We are not talking about that.
Yeah, I was thinking of that for the first two cases, that because there was the uveal effusion syndrome, you would have maybe identified alterations.
I am pursuing that angle very vigorously. Those changes you see in lot more entities, but we still do not know the interpretation, like how do we manage? Like for me, if I see dark spots for VKH, I know I have to treat it as VKH. If I see anastomosis, I do not know what to do. It just indicates that there has been a pressure on the choroid and you have to look for it, but it does not help in management because there are myriad of diseases which are producing that. Okay. Yes, last question.
A simple thing, looking back into the records of the patient with the non-ophthalmos, or those who have treated the patient first, hypermetropia of such a high degree, it could have made them clinch the diagnosis, at least coming to your center, madam, at least seeing the records that this patient is a very high hypermetro.
But you know, many times the excellence are not done in comprehensive practice, and this was long time back. This patient presented almost 12 years ago. So the things are changing now with more and more cases of, uveal effusion syndrome picking up like this. So even now it's becoming very common, and VKH is of course the first differential of UVS anyways.
But with this plus 10 or plus 14, I think.
So probably yes, that was missed by the treating ophthalmologist. I'm sure it was not seen.
And
because
doctor,
these patients, when we sit in the hall and look at the cases, we all become very wise. It seems, oh, they missed it. But in all honesty, when you're seeing in the clinic, a lot of people miss a lot of things.
I agree with that.
And when these patients present with, decreased vision, you attribute that decreased vision to the exudative detachment. Nobody looks at the refractive error.
Secondly, he was treated as CSC elsewhere.
Yeah.
I don't know, steroids were given despite the fact that the patient was having chronic serous chorioretinopathy. I wonder why.
So we cannot answer why the patient was diagnosed as CSC. His records indicated that he was subjected to all the differentials.
We did not give.
Yeah.
Good morning, ma'am. Just one last question. Just one last basic question then. For all the cases with exudative RD, when they come to our OPD, should we keep MRI as a first line of investigation also?
No, not as first. We should complete the ophthalmic examination first, including your slit lamp, your fundus, indirect ophthalmoscopy, of course the ultrasound, excellence, refraction, and do the imaging, autofluorescence, OCT. If the detachment is massive, sometimes OCT is not possible. You're not getting good clues. But yes, subtle detachments, OCTs, and autofluorescence and FFA ICG, if you have, various differentials in mind.
Thank you. Thank you, Reema, for very interesting cases. We move on to our next speaker, Dr. Anirudh Agarwal, who's from Cleveland Clinic, Abu Dhabi, and our alumni. He is going to talk about thick choroid in a patient with CSC. Is it a game changer? And the topic is important because everybody is talking about peckychoroid. And then there is a confusion, CSC, pachychoroid, the combination. So he's going to show us the cases to illustrate.
Very good morning. Thank you very much to Dr. Vishali ma'am for giving me this opportunity and to AIOS. So my topic is thick choroid in central serous chorioretinopathy. Now we all deal with pachychoroid, and this is a term that is being used many times to describe a number of entities. When it comes to central serous chorioretinopathy, there is some ambiguity whether to label it as pachychoroid always, or you may have some occasional cases where the pachychoroid is not so evident. But definitely you will have a subset of patients where the choroid is thick. And these have some implications when it comes to the diagnosis and management. So I divide this into three parts. One is that presence of a thick choroid itself can mean that there is presence of probably more than one disease, and I'll show you how. So apart from CSC, these patients could have associated conditions. Now also the second question that I'd like to answer in this presentation is, does a thick choroid mean more exudation or more fibrin? And finally, does a thick choroid have anything to do with response to therapy? Do some therapies work and do some fail? So let's see this particular patient who came to me very recently. So he's a young male with central serous. In the right eye, you can see that the choroid is thick. So despite your EDI-OCT, even in the Middle East, some of the patients have very much pigmented irises and also the fundus. So you cannot see the posterior extent of the choroid on the OCT. But definitely the choroid is thick. There are central leaks on fluorescein. And in this particular patient, again, you see the fluid is so much in the center, you cannot do laser. And in this patient, I started him on eplerenone. So this is at 6 weeks. I don't start eplerenone straight away, but I start usually after 6 weeks of observation. Now, within 2 weeks of eplerenone, this patient has a reduction in the fluid, and the patient has an improvement in the visual acuity. The scotoma has decreased. You can see on the infrared that the density of the scotoma, or the dark area in the infrared image, has decreased in size. Now, we have seen from studies that patients with thick choroid have a tendency to respond better to eplerenone. In general, with eplerenone, the response will not be seen in 100%. With most of the studies, we see that the response is only in 30%. But probably there are some patients with thicker choroid who will respond better. So if you have a patient with thin choroid versus a patient with thicker choroid, then expect a better response. If a patient has sick RPE, chronic fluid, thin choroid, you may not have sufficient response to eplerenone. I tried to study a lot of literature, and in fact I did not come across any manuscript which tells us the response of eplerenone based on the thickness of the choroid. Now, does CSC with a thick choroid mean that there is another disease which is coexistent? Now, if you look at this publication from the Progress in Retinal Eye Research, this study quotes that although choroidal thickening is a component of pachychoroid, CSC is traditionally included in pachychoroid. Remember, it is still a gray area because you will have some patients who do not have a clearly thickened choroid. Now let's see this patient. This patient has a focal choroidal excavation. So if you look at the multimodal imaging, you will realize that this patient has some pachyvessels. Look at these arrows over here. This indicates that under the RPE, this patient with focal choroidal excavation, and that can be seen here, has pachyvessels. Now, over a period of time, this patient developed subretinal fluid. So there is subretinal fluid near the focal choroidal excavation. Of course, it can happen because of a choroidal neovascularization, but this is a published case which is showing you that there is a CSC. And if you look at the NFAS imaging, you have large dilated vessels, pachyvessels, which are passing in the center around the focal choroidal excavation. So you could have more than one condition coexist. We talked about ICG in the previous presentation. ICG is no doubt very important in pachychoroid. It helps to pick polyps. Polyps can coexist with CSC, and Dr. George Manayat has a publication in Retina on that. And now we are moving towards analysis, automated analysis. So we, in our lab, we are starting to analyze the choroid using automated techniques and to look at the choroidal vascular hyperpermeability on ICG as well. Now let me show you this case. You might get confused with subretinal fluid and you might think that this is a patient where you would like to start eplerenone. So the OCT is showing you subretinal fluid, probably the choroid is thickened, and you look at the fluorescene angiography, you have some focal leaks over here. So be very careful if you have a thick choroid. This is a patient who has choroidal osteoma. So a subretinal fluid associated with choroidal osteoma can mimic CSC. So just don't go by the thickness of the choroid, okay? You have to look at a number of aspects, and we talked about how important the ultrasound is on the previous presentation. So this patient actually received PDT, and with PDT there is complete resolution of fluid. So this could be a mimicker of CSC. Now, does thick choroid indicate that there are high chances of fibrinous CSC? So let's look at this patient. This is a patient who came to us from Sri Lanka, and this patient has multiple leaks in the center. There is one leak in the superior, near the superior arcade, but most of it is central. You can see most of the leaks are central. Again, it's not possible to laser. And we often have these patients who come with such a picture. This patient was 636 with significant amount of fluid, and there is some amount of fibrin. So, of course, we didn't have any other option, and in these patients, you'd like to start on eplerenone. Now, this is about 1 month after eplerenone, and this patient was on maximum 50 milligram per day of eplerenone. There is mild reduction in the fluid, but not so much, and this is almost 3 months after eplerenone. So, the point is that you can have a patient with very thick choroid. You can see that on the OCT, the choroidoscleral interface is not clear at all. Even despite 3 months of eplerenone treatment, you cannot make out where the sclera is. And is it that, thick choroid with a fibrinous CSC will give you a suboptimal response? We don't know. But these are patients who are very difficult to respond. They may not respond to eplerenone or any other treatments, like laser is not possible. So you are faced with a challenge what to do. I'm showing you another patient.
Anirudh?
Yes, ma'am.
There is a question. I think
Please.
he wants to look at the slide. Yeah, please do.
Intervene, please. I'm sorry.
That's fine.
Yes, what is there in the retina?
You mean
in
this
all these images?
The
No, in the OCT scan.
The hyperreflectivity in the outer retina, you are asking?
Yeah, madam.
Yeah.
So this is actually the fibrin which is accumulated in the subretinal fluid, and if you read Bailey-Freund's papers, you will realize that this clear space that you see on the OCT, this is the area where the fluid is coming from. So that's why you will have a clear space, and the clear space is surrounded by that hyperreflective mass kind of a thing, which is fibrin. So this is all fibrinous exudation in CSC.
Previous, when you saw him first?
This one?
Yeah.
So here again, this is the fibrin, and you have a component of clear fluid. And of course, some of the outer photoreceptors are elongated, so which gives you those, long kind of hyperreflectivity. So this is the classic fibrin, how it appears on the OCT.
The eplerenone therapy had not worked.
So even despite eplerenone, this patient was on 3 months, no response.
Any other evaluation?
So this patient had a normal cortisol levels. We usually do late evening and early morning serum cortisol, free cortisol, and urinary cortisol, and vinyl mandelic acid. So we have a panel in Cleveland Clinic where we evaluate for an endogenous kind of a cortisol increase, but this patient was completely normal. This patient incidentally had multiple evaluations for other neurological conditions. The pituitary microadenoma was also ruled out. So we were left with nothing but to treat,
Then what was the modality of treatment?
So this patient was continued with eplerenone. We don't have any other, we don't have PDT yet. PDT could be an option. We are probably getting the dye, probably even in India in July or August. We don't know, but PDT could be an option.
Okay.
The patient was from Sri Lanka?
Yes.
I don't actually know the situation over there. Evaluation for tuberculosis?
Was not indicated because there was no inflammatory reaction. So we did not evaluate for TB.
Angiography images?
I'm sorry, I don't have
Let's
the
move on.
angiography.
I am being told to move on. You can discuss it with Anirudh after that.
But I will address some of your points. So in this patient, if you see, you have an exudative retinal detachment with multifocal leaks, and we're interested in the right eye at this time. So if you look at the OCT, there is subretinal fluid, and again, elongation of photoreceptors, thick choroid. This patient was not so difficult. We did a focal laser. The leaks were not so close to the foveal center, and the patient resolved. This is the right eye on the top, but the question is the left eye. The left eye has this fibrinous exudation and thick choroid subretinal fluid. This patient came to us after 6 months. And this patient, I did focal laser and a plerinon, and you can see that this patient took a long time to resolve. Again, it took about 4 months for the fluid to completely go away. There was nothing else we could probably do, and this patient ended up with foveal atrophy. So patients with a really thick choroid could predispose to fibrinous CSC. It could take a long time to resolve, and these patients can have a high chance of atrophy. So I think the expectations should be clear with the patient. When you see the patient, I think it's important to communicate with the patient that you may end up with atrophy and you may not regain complete vision. So again, thick choroid with chronic fluid, persistent subretinal fluid, one option is PDT. We may get the dye back in, at least in UAE, by July. Maybe it will come to India as well. So, but we're waiting to use PDT in some of these difficult patients. This is my last patient here. This patient is another example where you have a thick choroid and focal leaks in the center. You can see on the fluorescene. And this patient responded very well after PDT. And the important aspect is that PDT will give you something that a plerinon doesn't give you. PDT gives you reduction here at 2 months. PDT can cause choroidal thinning. So if you have a thick choroid, PDT is still an option. But if you have thin choroid, or if you have a very, sort of atrophic choroid, you cannot do PDT. Remember, a plerinon has no effect on choroidal thickness. So a plerinon is an option that you can use in both, but PDT, unfortunately, you can use only in some cases. Thank you very much. I'll be happy to take any questions.
Thank you very much, Anirudh. So with this, we will take up the questions at the end of the next talk, which will be given by Dr. Simar Rajan Singh, who is the youngest member of our VR team at PGI Chandigarh. So Simar is going to talk about polyps seen in patient with AMD. Does it change my management plan? Over to you, Simar.
Thank you. Thank you so much, ma'am, and thank you for having me part of this instruction course. So, coming on to the background of polyps, they are usually aneurysmal dilatations of the inner choroidal vessels. They are often seen at the end of an abnormal branching vascular network in the choroid, and they are characteristically seen in patients with polypoidal choroidal vasculopathy. ICGA till date is the gold standard for the diagnosis of polyps, and I think the Everest study gives us the diagnostic criteria for seeing the polyps actually, and the only criteria that is essential is focal hyperfluorescent lesions appearing before 6 minutes on ICGA, and that is actually what the polyps are showing up. So that is the essential criteria to diagnose PCV, plus any one of the other criteria. So that is the importance of polyps. So I am just moving on to the cases from here, a couple of cases. This is a 54-year-old female who presented with sudden decrease of vision in the left eye for the last 2 weeks. There was no prior ocular trauma or surgery, but she was a hypertensive and there was no history of diabetes. So this was the right eye, absolutely nothing to point out except some vascular attenuation attributed to hypertension. And this was the left eye of the patient. As you can see, there is a massive submacular hemorrhage, and as you may see that this color of the blood, this is the subretinal component of the blood, and this is the sub-RPE component of the blood, that is even darker and more well defined, as you can see. Doing an OCT through the right eye, I'm not sure if I would call these Pachy vessels. It appeared normal to me. And this was the left eye, which showed this was the subretinal component of the bleed. Lot of undulations in the choroid, hemorrhagic PED in the temporal area that we saw, and a notched PED over here. So yes, seeing the OCT, my first differential was polypoidal choroidal vasculopathy. We know it can be asymmetric, but still it was not sure. Since there was a lot of bleed at this time, I decided to inject the patient first and then maybe re-evaluate for a ICG exam. So this was the response of the patient with injection aflibercept, 3 injections given at 1 month intervals. And we can see that the both the subretinal and the sub-RP components largely resolved, and the patient gained vision also till about 6:36. At this point, the patient was planned for a FA and ICG combined on the confocal spectralis. And this is the right eye. Again, nothing really to point out here. It appeared normal, absolutely, both the ICG as well as the FA. And this was the left eye, early frames. And if you take a look at this in the left eye, this is at about 2 minutes. And if you take a magnified look, and remember this is after 3 injections of aflibercept, so you can see this very classical branching vascular network which is kind of pruned because of the anti-VEGF effect. And you can see this hyperfluorescent round lesions that are there, which are suggestive of polyps at the edge of the network. So this kind of clinched the diagnosis for us, and these polyps and the later frames would be, because they are just abutting the RP, you would see some changes on the FA as well in the late frames. So the final diagnosis was PCV, treat and extend with aflibercept was planned for the left eye, and watchful observation for the right eye. So the learning points for this was that the documentation of polyps helps in confirming the diagnosis of PCV. We have a lot of non-ICG, OCT and even OCTA criteria and clinical criteria available now, but the gold standard still stands as seeing those polyps on the ICG. It is important to diagnose it because it is important to counsel the patient accordingly and plan your treatment. PCV tends to have more asymmetry than AMD, as we just saw in this patient. One eye absolutely normal and one eye, and PCV patients tend to present more often with a precipitous visual loss with subretinal bleeds, and PCV patients tend to have sudden and worse recurrences if they are not kept on regular treatment. So it may be advisable to keep these patients on a treat and extend regimen with an anti-VEGF agent. So coming on to my second case, this was a 79-year-old male who presented with low vision in the right eye more than the left eye for the last 1 year. He was a known case of diabetes mellitus for 20 years, and he was recently diagnosed both eyes proliferative diabetic retinopathy with high-risk characteristics, right eye vitreous hemorrhage, left eye subhyaloid bleed with neovascularization. This is the diagnosis the patient came with, and he had already received 2 sittings of pan-retinal photocoagulation. So this was the right eye. It had a dense vitreous hemorrhage. It was grayish, not so reddish, so it was kind of a little bit old hemorrhage in that eye. So this was the left eye, if you see. So whosoever had seen this patient diagnosed this as a NVE over here, and these are the laser scars that you can see that were done for the pan-retinal photocoagulation for 2 sittings. So just zooming in on these findings if I can, this right here is kind of a subretinal bleed which was considered as a NVE. You can see lot of exudation in the subretinal space all along the posterior pole. And then right at the edge of the posterior pole arcades, you can see these subretinal mounds that are present, which were present. And just zooming into that area, this is the area of a subretinal bleed. You can see the vessel passing right over it. And then further, this was the area of a sub-RP, a more darker lesion. And within that lesion, you can see some orangish kind of things, which may be indicative of polyps or nodules over there. But we are not very sure looking at this picture what we are dealing with. And the another lesion in the inferior nasal quadrant and some healed or scarred lesions in the superior temporal quadrant along with the laser scars. So this was the picture. So clinically we made a diagnosis of PEHCR, that is peripheral exudative hemorrhagic chorioretinopathy, which is considered to be a peripheral variant of PCV. And we planned for an ultra-wide field ICG to confirm our diagnosis. This was just the FAF showing the routine findings. And this was the ultra-wide field FA first, which did not reveal any diabetic retinopathy at least. And coming on to the ICG now, so this is the wide field ICG on the optos, and if you can clearly see, carefully see here, these areas that we were looking where the orangish nodules were. So you can see these small whitish dots that are coming up over there, and they are right at the edge where the bleed is. So they are very much indicative of polyps, and this was again at about 2.5 minutes that they showed up. And this is the late frame of the ICG. The OCT did not reveal much in the center, some pachyvessels, but some subretinal exudation, and some RP undulations as you move towards the periphery. And this is the OCT that is passing through that lesion that we are talking about, where you can see a thumb-like PED over there with the subretinal bleed over it. So the final diagnosis was confirmed as PEHCR, and the patient was planned for left eye aflibercept 1 monthly for 3 injections and then treat and extend, and the right eye was planned for pars plana vitrectomy and then take a call for anti-VEGF in that eye. So this is the follow-up of the left eye. You can see with the 3 injections, the lesion kind of resolved, the subretinal bleed resolved and kind of scarred out over there. And you can see the posterior pole, remarkable clearing of all that exudation, and the patient improved to about 6/18 vision in this eye. And the other eye was obviously operated, and that too showed very similar findings in a little more advanced stage with more scarring and the leopard skin appearance that we just saw in a talk earlier. So the ICG was repeated at this stage to see for resolution of the polyps, and we can see that we could no longer see any of those lesions on the wide field ICG at this point of time, and the right eye did not show any activity. So the learning points from this case were that PEHCR is maybe a variant of peripheral PCV. Polyps can be documented even in these cases with a wide field ICGA. And again, this is also known for recurrent and massive bleeds and can lead to complete loss of vision in these patients. And such cases are known to progress from periphery to the center. So again, it might be advisable to keep them on a regular follow-up and maybe on a treat and extend regimen. Thank you so much.
Thank you very much, Simar, for the very illustrative cases. Now we can take up questions both for Dr. Anirudh Agarwal and Simar.
Dr. Simar, we actually did research on PEHCR in 2009 in Retina Institute of Karnataka, Bangalore. At that time, Eylea was not available, but the Lucentis and all other like steroids and modalities were, you can say, were not giving any benefit to these patients. Then we did cryo, and it worked. So I think if the polyps are in the periphery, and you have a lot of blood, I think better to start with the cryo rather than going for, you can say.
Absolutely, I agree with you. Laser as well as cryo are very effective methods for
you can't do the laser. You can't do the laser because there is a lot of blood. And the periphery, you have to do that LIO and all, and it's difficult. How you will localize by the LIO? Otherwise, even on the slit lamp, it's very difficult to localize and to kill those polyps. I think cryo is a better option.
Absolutely agreed, but the point is that once they bleed these polyps, they kind of scar by themselves in a lot of these cases. The idea of the
if they scar, then why we inject?
Then the idea of the treat and extend is to subside the disease, basic disease activity. They have come back with a more bleeding and much more kind of activity in the later stages, and the same goes for PCV as well.
Yeah. If on the ICG you are able to see the active polyps, then we should proceed with either the cryo as per my experience or with your Eylea.
Absolutely.
I think if anti-VEGF you can get away without producing much of inflammation and scarring, you know, you are talking about the time when aflibercept was not available. So cryo itself is going to induce inflammation and some scar, and if you do heavy, you know, it can be. So it is an option which is a very effective option, but maybe one can try the less, you know, the better options before now that we have a choice.
But the problem with the PEHCR is that ma'am, how to judge the treatment response? There is no SRF.
There is no end.
There is no SRF. Posterior pole is quiet, vision is good. Then how to judge?
So that is very difficult to judge.
That is why the wide field you have to look for
the ICG after the 3 injection.
And doing again and again, and that this ICG is not a so easy job in these patients, and the morphology changes. Morphology of these, you can say, blood mounts and all, it changes after every month or so. So it's very difficult to measure the treatment response.
Absolutely, and that's why you also want to be very gentle with the treatment, both things, yes. So, yes, doctor.
Dr. Anirudh, you showed the last patient in whom PDT was done for CSR. For how long was the patient followed up?
The patient had a total follow-up of 6 months, and the treatment response was about 2 months, I think, if I'm not wrong.
Actually, I am concerned about was there a development of CNVM?
So this was half fluence PDT.
Half fluence.
Half fluence, and usually CNV is not very common with half fluence PDT. So
for CSR, we do half fluence only.
Yes.
We had a question from there. Yeah.
I sometimes wonder that is the diagnosis of pachychoroid a physician bias, because Anirudh showed a few cases where he saw that there was CSR, but the choroid was not very apparently thick, and he called it as pachychoroid. Simmer showed a OCT where there were larger vessels, but he did not call it as pachychoroid. So until we adhere to a very strict definition that there is an associated attenuation of choriocapillaries.
You are absolutely right. Pachychoroid is not a diagnosis. It's just a morphological finding where you are seeing large vessels, they are compressing the choriocapillaries, and Rick Spade is going to challenge the whole concept and the diagnosis of pachychoroid very soon, you know. So I agree with you, we are getting too much carried away making the diagnosis of pachychoroid. Pachychoroid is a finding, it's not the diagnosis. So I think in the coming years, the direction will be what you are saying.
My question is from Dr. Anirudh. The cases you showed were of acute CSC?
So yes, there were some cases of acute, but the last case, for example, where PDT was done was a chronic CSC.
So normally we don't treat acute cases. So
Yes.
for your cases, you started with the treatment and you were considering PDT also. So I think medicine and epinephrine and PDT is for chronic cases we are dealing.
Yeah, that's what I said actually. I don't treat for at least 4 weeks. I do not give any treatment. But some of the cases, like for example, one had an exudative retinal detachment with fibrin. Now, if you have an acute fibrinous CSC, then that becomes an indication to treat, even if it's within the first week, because you don't want the fibrin to accumulate, cause atrophy. But if you have a plain, simple acute CSC, I don't treat for 4 weeks. I do not give eplerenone. Although, for example, some of my colleagues, like Francesco, he has led a trial on eplerenone in CSC. He starts eplerenone during the first visit in acute CSC, but I usually don't.
Well, that brings us to the end, and you guys have been a wonderful audience with so much interaction, and I loved it when you stopped it in between the presentation to clear your doubt. Thank you very much for being with us this morning, and we look forward to next year in Cochin, I think. Thank you.